So when you're using the HA peak, what are you adding for a biologic in the cervical spine? So what are you using to fill your cages?
Yeah. So actually, there was one thing that prompted me to use this material. I like it that it's totally standardized. That means that every cage you take out of a package is going to be exactly the same as the previous one. So, and then I combine it with when I do my ACDFs. I typically I'm a stickler for having the plate flush to the bone. So I typically resect the marginal osteophytes with Lexel Roger. So I harvest like a little bit of those marginal osteophytes with Lexel, and then combine it with DBX. So it's DBX and those little osteophytes that you always get from those marginal osteophytes, and so really nothing else. So it's kind of very straightforward, very standardized.
Yeah, I think it's worth mentioning, Christof, that I think that experience with just using some DBM, marginal osteophytes, and a peak cage is something that I think your experience has been really positive with that, with the HA peak cage. One of our former fellows here at UCSF, Khoi Tan, published a very powerful series suggesting that the standard peak, peak alone, really had a relatively higher non-healing rate in the cervical spine compared to allograft. And I think that the HA peak really makes a measurable difference. It was quite apparent in the preclinical studies, and I think your clinical experience also confirms a measurable difference between the HA peak composite compared with just standard peak.
Yeah, I think it's a real change of the properties because, again, as I mentioned during my part of the talk, often with peak cages you see fibrous material around the cage and then no real apposition of the bone. At least on the CT scan and what we see from our imaging, it's again, as I pointed out, at three months already, you see that very dense bone surrounding those cages, which is very different from typical peak cages. And one other thing in Khoi's study was that he compared mainly seroprofiles to autografts and allografts with plates. I mean, there was a little bit of that study had some other differences between the groups. So, but I think it does change the properties entirely.
Yeah,
what do you use for your?
In terms of. So that was going to be the point, is that I think there's the opportunity to really be biologic sparing in some of these cases. And what I mean by that is that historically, when I used peak for my ALIFs, historically I routinely used BMP with the mastograft for the anterior interbody. And I certainly feel much more comfortable using either allograft to fill my HA peak composite cage or even a synthetic matrix for the subset of patients who prefer to avoid the BMP. And so
you normally routinely use a little bit of BMP or not for ALIFs?
Normally, most commonly I do use BMP, but certainly there are circumstances, including my tumor patients or some of my younger patients, my patients who may be of reproductive age, where I have been avoiding BMP, and in those instances, I've been much more comfortable avoiding BMP with the HA peak composite than I would have been with a peak cage only.
Yeah, I like the standardized nature of this in comparison to other biologics that differ from harvest to harvest, and so I think that's once that study is completed and stuff, I think it's going to be really interesting how much we can decrease the use of BMP in the lumbar spine. So I still use an extra small BMP for anybody except for young people up to 35. I just use some allograft, but above that I use it extra small and DBX. For
the other area I've had a lot of experience with is lifts and T-lifts, and historically I've published quite a bit on favoring titanium as a material for interbody fusion, and indeed I've had good experiences with titanium. The trouble I have with titanium in a lift for a T-lift is, again, being able to see my fusion, because so many of the different titanium cages I've used over time have really got a very large footprint, and I think they're really somewhat not the most pleasant in appearance on a post-operative X-ray sometimes. So I think some of the advantage of the HAP composite in the PLIFs and TLIFs is perhaps a more favorable radiographic appearance and the ability to really see bone going through the cage. That's one of the real limitations I found with titanium. What are your thoughts about that, Christof?
I think the post-operative imaging is just as pointed out. Today I had in clinic at a 3-level ACDF from 3 months ago, and it looked like a spitting image. It's just I don't know if you can see it better, but it's just I'm fascinated by this almost cortical appearing bone that sort of surrounds these cages as early as 3 months afterwards, and I think it's, as you mentioned, I think partially that we can see as there's less scatter and less, signal from the cage. But I think it also has something to do that the elastic modulus is there. And again, we see that in the lab with a lot of transplant experiments we do in different parts of the body. I think that having the elastic modulus in combination with a hydrophilic surface, I think makes a tremendous difference. And I think it's really exciting to think about the opportunities and the possibilities that are really open for material like that. It's not a one-way street. It's really, I think an exciting way forward how to change this type of material and modify it to even make it more appropriate and even better for certain applications.
We've got a question here in the Q&A section. The question is, can these HAP implants also be used both for load-bearing and non-load-bearing regions? So the question here is, for example, for a non-load-bearing region, so certainly our antibody grafts are going to be load-bearing, and going back to the work of Flower, you suggested that really having something structural that can maintain that disc height or restore the disc height after discectomy is really what we're going for here. But in terms of perhaps a non-load-bearing region, in general, I wouldn't really be using an antibody implant for something that was non-load-bearing. I think if I were going to graft something that was non-load-bearing, I'd probably use something like either autograft that's morselized, or perhaps even morselized allograft. But Christof, have you ever used grafts in non-load-bearing regions?
No, I mean, I agree with you. I think, I do a lot of giant sacral schwannomas, and so they often sort of leave large defects of S1 and S2 vertebral bodies, and I typically fill that up with allograft or autograft. But, again, as I pointed out, there have been studies, or initially the idea was with HAP to develop is it a bone void filler. And I think it would actually be interesting, given the tremendous potential of bone on growth, how this material would do as a, almost like a kyphoplasty sort of type of material. Because it would rather than just adding cement, you actually would stimulate the endogenous sort of osteoblasts. So I think it's an interesting, fascinating question, and I think the results would be probably, I've not used it, but I think it's an interesting question.
Yeah, I've got not much to add to that. I think at this point that's preclinical at best. The last point I'd want to bring up, Christof, just again sharing some of our experience. We wrote a paper some years ago now looking at subsidence of our cervical interbody implants. And again, this was an area where we found that the allograft tended to do a bit better than titanium, but actually our P cages tended to subside the least. And that's one of the areas where I really find that the HAP composite, I'm very positive with, is I really haven't seen much subsidence either my lumbar interbody implants or my TLIF or PLIF implants. My use in cervical spine has been limited with this so far, but the absence of subsidence has really been a very favorable experience that I've had with the HA peak. And have you noticed that as well?
Yeah, I've been, I used to use allograft, so I came from allograft antibody graft in the cervical spine filled with biologics. That was my go-to. And I saw that, first of all, in a lot of patients, the allograft was not really integrated or reabsorbed within the 1-year follow-up time. And also the allograft ring often subsided. And so, as you pointed out, all the films I've shown, and again, for the most part, same thing here. We don't see as much subsidence. I think it's also due to the larger footprint of these cages. There's medium, a small, medium, large, and the large is really in a larger patient with more solid bone. That's really a graft to go to. I don't know if it's because it fuses so quickly. I mean, as you pointed out, I think there's going to be failures and there's going to be subsidence, but certainly it appears very favorable. And I think again, I think we're collecting the data right now. We routinely do CT scans at 1 year, and so I think right now we're collecting the data, and the data is going to will be shown and published. But yes, I think I concur with your observation. It seems to be for me. There's no way back. Let's say like that. I'm not going back to allograft.
Well, Christof, I know that you and I look forward to looking at the registry. Dr. Oka tells us that we're now up to over 1,000 patients in the registry, so we'll have more to share in the months and years to come. But so far, I think the conclusion for both of us is that we've had very positive experiences with the HA peak, and the evidence is very supportive with preclinical and clinical data. So with that, I'll thank everybody, all of our attendees through the Academy website, and I'll look forward to further discussion in the future.
Great. Yep. Thank you so much, everyone, for listening, and please feel free to reach out to either Sigurd or me if there's any questions or if there's anything else we can help with. All right. Stay safe out there, and thank you so much for listening.